reduce the severity. So the supplementation of magnesium is not going to reduce the severity of withdrawal. It just may give you a satisfaction of supplementing magnesium. I won't go into the details of these. Of course, thiamine, once you finish with the injection, you get onto the oral thiamine if possible. And fluids and electrolytes you have to look into, but the other interventions I think will be covered in the next lecture. So we'll go to delirium quickly, and that will be the last part of this. Most severe form of alcohol withdrawal, delirium tremens. Okay, it has to be treated as medical emergency because it can lead to morbidity as well as. How many of you have seen delirium tremens? What kind of a picture can anyone? Every patient goes into delirium, is it? Is it that often? No. As we said, no, it's only 10 to 15%. But somewhere in your tenure you have seen. So can you, like, if I have to draw a picture, if an artist's view of delirium, how would it be? Disoriented patient, hallucinating, picking behavior, agitated, violent, anything else? So he could be? That is when you take it, measure it. I am saying when you picture it, he could be incontinent, right? He could be responding to hallucinations and running after something, etc. What are the common hallucinations in delirium tremens? Auditory? Visual are more common. And what are they like? Have you ever asked any patient? Animals? Insects? Anything else? Sorry? Religious. Common? They've not told you that they see reptiles crawling towards them. They see small human figures. The army of small human figures coming towards them to hit them probably or to attack them. What are those called? Lilliputian hallucination. Where does this Lilliput come from? Everybody is aware of this? Gulliver's Travels? Yes. And Lilliputs are the small people, because many a time some people, when they hear this question, it sounds Greek. So, Greek to them. So that's why it's important to know that Gulliver's Travels is a story in which there are these small people called Lilliputs, and these people hallucinate in such a way that they see small humans coming, and that's why they are known as Lilliputian hallucinations. Okay? So they are very common. Delirium tremens it can occur within 1 week when the patient stops drinking, but as we have seen, it comes usually within 2 days of stopping, and if untreated, the mortality rate is 20%, so it has to be treated as an emergency. We've already seen that they may have fluctuating levels of psychomotor activity, perceptual distortions, and autonomic hyperactivity. In other settings also, if the patients are hospitalized, then many times you must be receiving calls from other units, other faculty, that the patient is behaving abnormally, and when you go to see, the patient is admitted for some other reason in the medical or surgical ward, and he has suddenly stopped alcohol because of that problem and has gone into delirium. So 5% of all alcoholics who are hospitalized do have delirium, so they may be hospitalized for other reasons also. And episodes of DT usually begin in the 30s or 40s after 5 to 15 years of heavy drinking. As we spoke about seizures, the way kindling happens, the same thing that it comes up a little later. And physical illness, if it is present, it would predispose. We've already seen predictors of alcohol withdrawal, but physical illness would also be a risk factor for becoming delirious. So we already established a IV line. We give diazepam or IV lorazepam, thiamine to. Okay, why give thiamine? So what? It is C. So why are we insisting on giving thiamine to?
If we need to give the oral IV fluid, so we need to give the thiamine.
Why?
And actually, thyroid.
Yeah. So we why can't we give dextrose?
Because thiamine deficiency.
But what is the role of thiamine? That's what I'm asking. One person can stand and answer the correct everything. Everybody knows the answer.
It is necessary for G6.
Yes. One person. Yes. Somebody was giving that answer. I heard it. What is the substrate for what?
Krebs cycle.
Yes.
Phosphate is the enzyme which is required
Correct.
for the continuation of the cycle.
Yes.
Thiamine is not there, then energy won't be produced irrespective of the dextrose present.
Correct. So A, the patient may have neglected his nutrition and he may have thiamine deficiency, right? If you don't replenish thiamine and give dextrose, then what will happen? What will happen?
There will be precipitation of as the patient doesn't have when the carbohydrates already the patient is already malnourished. So if dextrose is given, there will be overt thiamine deficiency.
Correct. You will precipitate an acute thiamine deficiency by giving dextrose, isn't it?
Hemorrhage in the mammillary cord.
Correct.
Precipitate the Wernicke's encephalopathy.
So what we are dreading is Wernicke-Korsakoff syndrome, which is a potential in everybody. No, each alcoholic has a potential of developing that because of his nutrition and alcohol consumption. So every patient would be prophylactically given thiamine to avoid this Wernicke-Korsakoff syndrome. Of course, the environment, protected, safe, etc. is again repetition, and the diet and hydration. So it brings us to Wernicke-Korsakoffs. What is so great about or what is so bad about Wernicke-Korsakoff? What is Wernicke's and what is Korsakoff's? You have heard these terms, right? We just also said that if we don't give thiamine, we can precipitate it. So what will be precipitated? Acute thiamine deficiency would be Wernicke's encephalopathy. And what does that? What is it characterized by? So, correct. Confusion, ataxia, ophthalmoplegia. This is a triad of Wernicke's encephalopathy. It's also called, it's classified as alcohol-induced persisting amnestic disorder, and the syndrome is characterized by acute neurological disorder with ataxia, confusion, and a variety of ocular motor abnormalities. Then if this is already precipitated and you can see these signs, then we require larger doses of parenteral thiamine, which would be effective in preventing the progression to Korsakoff syndrome. So that means you are at a level which is reversible. So in that state you already saw the signs and you became aware that this is Wernicke's and you replenished with thiamine, which would be given for longer time. So usually if you give for 10 days, this may be given for 15 days or 20 days and then oral thiamine after that. So you would have prevented Korsakoffs, which is what have you prevented? Even Wernicke's is amnesia, right? But what is? It's an irreversible thiamine deficiency in which what happens? Severe memory loss with confabulations. And what are confabulations? There are memory gaps and the patient keeps spilling. This is like spinning a yarn. So if the patient does not remember, he just fills it up with any answer. That is Korsakoff syndrome. So profound impairment in recent memory and disordered time sense in the absence of generalized intellectual impairment. So that is what is important, and it would differentiate from dementia. Gaps in memory, which are often filled by confabulating, and again you would give treatment of thiamine for much longer duration. It could be continued for a few months. So, concluding, detoxification can take place in either inpatient or outpatient, and we saw when it can be done outpatient vis-a-vis inpatient. Then an accurate assessment is essential, which we've already learned in an earlier lecture, but we also learned here that what are the typical factors which we have to ask, which will tell us that this may go into severe or this will be a mild withdrawal. So we will decide the treatment setting and treat accordingly, and treat with mainly benzodiazepines, and we will take care of the other supplementary and symptomatic treatment also. So it's common, it has increased excitatory neurotransmission. If untreated, it can lead to morbidity. Therefore, we will treat with the safest and the cheapest treatment that is available with us, and that is benzodiazepines. Only thing is, once the alcohol withdrawal, if you do this by SIVA or if you do it by your clinical assessment, once the severity of withdrawal is coming down, your dosage of benzodiazepines are also coming down. So by 7th to 10th day, depending on the patient, your benzodiazepines will be tapered and completely stopped. That is very important. Try and finish it when the patient is with you. If it is on OPD basis, see that it's supervised, and then you take it off, because we don't want to send the patient home on benzodiazepines, then he continues to misuse it and then lands up in a benzodiazepine dependence from alcohol dependence, right? So that part we have to take. So we take care that that does not happen. Thank you.